Hello, everybody. My name is Rachel Inman-Segura, and I am here to give you guys the lecture for fluid and electrolyte balance in pediatrics. Just a quick background about myself before we move on. I am a nurse practitioner. I also worked as a nurse inpatient in pediatrics for about 8 years, as well as in the NICU. As a nurse practitioner, I've done some pediatric primary care, some urgent care, and I now do per diem work for concussion care, which, you guessed it, has a lot of pediatrics in it. So I did want to let you know this is my first ever recorded PowerPoint/Zoom meeting, so there may be a few technical glitches here and there, and for that I apologize ahead of time. So let's jump into this. I know you guys' time is valuable. You've got a lot going on, so let's get started. So fluid and electrolyte balance in pediatrics. So review of objectives. You guys are used to this. It's in all of your lectures. So we're going to look at the basic fluid and electrolyte principles. A lot of times I've shortened that to F&E, just so you know. I know some of this is review. You've done this in med-surg. You've done this in other courses, but we're going to kind of focus on how we do this with pediatrics. So we're going to look at evaluating the health promotion factors in relation to peds, including fluid and electrolyte balance. We're going to look at the information we would need to be talking to parents and families about, guardians, regarding how patients are going to be kept hydrated. It's a lot harder in pediatrics. You can't just reason with a 3-year-old why they need to be drinking right now. We're going to look at caring interventions to determine the kind of monitoring we're going to do for pediatric hydration status, because again, they can't all talk to us. They can't tell us how they're feeling. They can't tell us their mouth is dry. So we really got to be paying more attention and looking at those cues. We're going to look on communicating that patient status effectively with both the caregivers, whether that's parent, guardian, as well as the providers and the ancillary staff that we work with. And then also maybe touch on some of those legal and ethical considerations that have to do with kids. And you see this a lot in the elderly as well, but you can come in and have a kid who's severely underweight. We might have malnutrition or that failure to thrive, which we call that FTT. So fluid and electrolytes, which is really just the process of regulating the fluid volume, the body fluid osmolality, and the plasma concentrations of electrolytes. So that's the straight up basic definition, and we'll go into that a little bit more here. So the things we're looking at in alterations in the F&E balance, there is temperature that can cause that, acid-base imbalances, which should again mostly be a review for you guys, as well as fluid and electrolyte imbalances. So starting off with a history and assessment, and I put up here for temperature just because that's what we're talking about right now. There is something that I like to use called old carts, and I learned that I think as an NP in school, but I wish I had learned it as a nurse because it really helps you get an idea of what's going on with the patient, whether that's because you're asking the patient or you're asking the parent as far as that's concerned. So I put it down there for you so you can see what that acronym stands for. So old carts would be onset, location, duration, the characteristics of whatever that would be, aggravating or relieving factors, what treatment they've tried at home, and the severity, like how bad is it? Are we unable to get out of bed? Are we unable to keep any water down? Those are all things that we want to ask and kind of pay attention to. And we will go through that with an example just to give you a better idea of how that kind of plays out. And then as far as news goes, that's the nutrition. What are we eating? Elimination. Wet diapers. Are we not having wet diapers? Are we having diarrhea? Are we having firm stools? The W is work/school. Are we able to go to school with whatever this illness is? Are we able to go to work and then sleep? Are we sleeping through the night? Are we not able to? Are we up? Those are all things that are going to kind of help us figure out what's going on in pediatrics with this kiddo, right? And just like regular nursing assessment, right? We're looking at the overall appearance and behavior. Are we crying? Are we sleepy? Do we wake up easily? Are we happily playing with mom and dad? Do we look fearful? Those are all things you want to pay attention to. And again, in pediatrics, you're not going to have the opportunity for somebody to tell you always what's going on. So you really got to pay attention to how that kid looks and what their behavior is. Physical assessment, again, is the same. That's going to include your vital signs. With the temperature, there's a very good chance you're going to see that increased heart rate or increased respiratory rate. In a physical assessment, we definitely want to include in pediatrics a weight as close as you can to naked, and we'll talk about that more in a little bit. So as far as diagnostics go, I have that all here on this next slide. So fever in itself is not a diagnosis. I think we all know that. Fever is always caused by something, right? There's an etiology behind it. They have a stomach bug, they have appendicitis, they have something that's causing that fever. So labs that are common that we see would be like a UA, CBC, and a CMP or a BMP. Especially in infants who come in with fevers and they really aren't showing a lot of other symptoms, that UA is super important because that's the only cue you're going to get for infants is going to be fever. So we really want to make sure to check up on that. CBC, of course, can show us if we're having some sort of infection, and the CMP is going to give us the electrolytes. We can see some inflammatory markers. We're going to see the glucose. We can see some acid base on that, all super important. Lab values as far as kids go are all generally about the same, but I did include this link here that you can get onto. It is a CBC reference value table for peds. It's very specific. Again, you can see it's just shifted a little bit here and there for different ages. It's not always used that specifically in real life on the peds floor. Excuse me, a lot of times you're still going based off of what the lab values at the hospital give you to go off of. So temperature changes. Who has the greatest risk for those temperature changes or those drastic temperature changes? So that would be infants for several different reasons. One being the lack of insulation, right? They are little scrawny things. They don't have a lot of that sub-Q fat. They have poor capillary reflexes, and they don't have that shivering reflex. So they aren't able to kind of keep themselves a little bit warmer. Granted, that's not quite for the higher temperatures, but still it's something to keep in mind because that's how infants are. They also have that greater surface area versus the weight that they have, which can also affect how their temperature is. So the fever can cause that increased metabolic rate. It can cause increased oxygen needs. They may end up breathing a little bit faster because they're needing more oxygen, and the increased caloric requirements. So meaning that they're not getting as much. They may be drinking their regular amount of formula, they may be drinking as much breast milk as usual, but they're working so hard that they're burning off those calories and not gaining the weight like they're supposed to. And then fluid loss, again, like we said, that surface area versus weight. So, and why do we get fevers? Well, we get fevers because of something else, right? They're always going to be based on that other something, whether it's an illness or something else going on with the body. So things to look at as far as nursing process and things to pay attention to. Short-term goals for some sort of fever. We want to decrease the fever, right? And we want to increase the fluid intake, which is going to help with that as well. Some kiddos feel a lot better drinking fluids once they're not as hot. They're not as likely to be drinking and eating when they feel so uncomfortable from that fever. And then a long-term goal would just be to return to our baseline. What is our normal for this kiddo? Like that's where we need to be. So as far as expected outcomes, again, that's more, we want to fix whatever the etiology is, whether that's because we have a fever due to influenza or we have a fever due to appendicitis. We got to kind of work on that etiology. Especially for families of really young kids, we really want to focus on that education. Proper temperature taking is huge. When to call or return to the clinic for further information. If you have somebody that says, oh, well, we've had this fever for a week, that's a big difference other than, well, we've had this fever for 24 hours. And this education is important when the kid is sick, but if you're working in a primary care office, these are things that you want to talk about during, child checks too. Bring it up. Hey, like if we're seeing these things, we want you to call us or let us know, because a lot of times families, with young kids, this is their first child, they may not know things like that. So as far as fever interventions go, one of the things that you can anticipate, of course, for orders would be some sort of antipyretic. That would be acetaminophen or ibuprofen. They come in several different routes. Obviously, as an outpatient, you're not going to be giving IV acetaminophen, but as an inpatient, you might. And the reason that we would choose that is it has a faster onset. It's going to get to that kid faster if they've got a really high temperature, or if their GI system is just so compromised right now that they're not keeping anything down. This is a good way to not only get this acetaminophen in them, get their fever down, but if we're already getting IV access, and I'm jumping ahead here, we can work on getting some fluids in their system too. So there are different concentrations for ibuprofen and acetaminophen that are over the counter as well. There is liquid and there is a rectal version. Obviously, there are tabs too. You can get those for older kids, but typically those younger kids are going to need the liquids. Definitely make sure to pay attention to the concentration. When I just started out in nursing, they still had an infant version of acetaminophen as well as a child version, which led to a lot of people having near oopses on the pediatric floor because the infant concentration and the pediatric one were so different, and you didn't always know what the pharmacy was going to send up for you. So always make sure you're checking your concentration. That's a normal nursing rule, right? As far as rectal dosing goes, that can be really helpful again for infants, especially if they don't want to take the medicine, they're not interested in eating and drinking right now. The biggest problem with rectal dosing is that if you have to cut that suppository, it's hard to be super accurate as to how many milligrams you're getting. You can choose to weigh it. Again, that takes kind of a long time. And if you are busy and on the floor and running around with multiple kids, it's hard to do that. So liquid is typically your better choice, but you can always contact the pharmacist too and have them help out a little bit with that. So as far as oral hydration goes, we're going to talk a little bit more about that in the future as far as what our minimums are and what we're supposed to be having. But as far as pediatrics go, we definitely want to get creative with what we're drinking. Popsicles, Pedialyte, things like that are all important. And then as far as alternative cooling measures go, there are things that it's really what you think it would be, right? It's taking some layers off. It's putting a cool washcloth on somebody's face. Those are all things that are important as far as getting those kiddos cool. And then again, they may end up starting to drink and eat because they're feeling a little bit better. So as far as dosing goes, acetaminophen is typically 10 to 15 mg per kg, and you're going to give that every 4 to 6 hours or per whatever the order is that you're given. I jumped ahead there, and I already talked about routes, but again, there's IV, there's oral in both liquid and tab, as well as a rectal route. So ibuprofen can be 4 to 10 mg per kg every 6 hours or so. We are not giving that to infants under 6 months old. Your physician or provider should know that, but it's always good for you to be aware of something like that as well. When you have kiddos that are pretty sick, we do what we call round the clock or RTC fever management. And there is a way that you can kind of get creative with your acetaminophen and ibuprofen dosing. If you kind of write it out on a calendar, essentially you can give a dose of either acetaminophen or ibuprofen, excuse me, as long as it's ordered, every 3 hours. That keeps the fever down. You do not want to do that for over 24 hours, just because we want to make sure that the fever is kind of slowly going away on its own. And again, that will depend on your etiology, right? Why do we have this fever? As far as aspirin use goes, this is typically just a no-no in pediatrics. There are varied things. Some say anything over 4 years is okay. Some say 16 years is okay. And quite frankly, that is too big of a gap for me to say any pediatric should be using it. And the risk would be because they could get Ray's syndrome. So here's a practice that we can go through as far as dosing out our Tylenol for a kiddo. So Carl is a 3-month-old infant. He was brought to the urgent care by his parents, and their biggest complaint right now is fever. So his current weight is 14 pounds, 1 ounce, and then his vitals are as follow. We got a heart rate of 154, respiratory rate of 44, temperature of 101.3. I did not put that in there, but let's say that's axillary. And his O2 looks great at 98%. So we're not getting any of the other information in here, but the provider said, hey, before we do anything else, let's get this kid some Tylenol, right? He's miserable, his fever's kind of high, so let's work on that. So they ask you to give oral acetaminophen at 160 per 5. Okay, so what is our appropriate dose range for Carl? So first we know we have to take his weight and turn it into kilos, right? Because that's how the dosing is 10 to 15 mg per kg. So we are going to take 14.1 and divide that by 2.2, and we get 6.4 kilos. So let's just say we're going to give that 10 mgs per kg for him, right? So 10 times 6.4 would be 64, right? If we were going to give 15, it would be 15 times 64, which was equal to 96. So figuring out that concentration, this should mostly be review for you guys, but I understand sometimes you throw in the word pediatrics and it gets scary. So at a 5 mil per 160, if we do that 10 at 64 milligrams as the dosing, he would get 2 mils. So we can go through that more in detail during the live lecture. If you guys need a little bit of help with that, just make sure to let me know, okay? So on to acid-base imbalance. So as far as history and assessment goes, back to this old cartoon news, right? Why are you here? What brought you in today? Like mom, dad, grandma, whoever's here with kiddo, why are you here? What brought you in? Because as far as a acid-base imbalance, you're not going to know that based on a symptom, right? They're going to be coming in with complaints of something else. This imbalance is going to be secondary, just like a fever, to something else going on with this kiddo. So let's ask those questions and find out why they're in here. Yes, the provider is going to go in and ask questions too, but the more thorough that you can be yourself, the more helpful it is to the whole team taking care of that kiddo. As well as, you know, we all know that you can go into a room and you ask something of somebody, you ask them all the questions and you leave. And then the person that's precepting you or that you're following goes in and they ask those same questions and sometimes they get different answers. So, and it's never fun to do that. So the more questions you can ask to have more information, the better off you're going to be. So as far as acid and base imbalance goes, again, overall appearance and behavior, you're not going to see anything that points to acid-base imbalance. You're not going to say, oh, this person's coming in and they definitely have this. You're going to see symptoms. You're going to see symptoms that might lean towards something, but you're not going to know by looking at them. So again, get your vitals. You want to get your weight and height. And as far as diagnostics go, I think we've got some more here. Yes. So just a little bit of a review again. Acidosis, just a decreased pH. Alkalosis is an increased pH, right? Our neutral is 7.35 to 7.45. And there are two types of imbalances and compensation. So respiratory and metabolic. If you are respiratory, you can quickly compensate for some sort of metabolic by adjusting your rate or depth of your breath, right? We speed up our breathing. We're taking big, deep breaths, right? And then for metabolic, those kidneys can excrete the hydrogen ions into the urine, or they can be absorbing the bicarb to kind of offset what's going on there. So, and why do we think infants and young children would be more vulnerable to imbalances? I'm going to leave that to you guys to think about before we get back to this in the live lecture, okay? So here is just a nice table that kind of gives you some examples of what could cause these things. Acidosis is caused by that extra CO2 in the blood. So you could have airway obstruction such as asthma. You could have cystic fibrosis, which is something common that you'd see in pediatrics. You can also get that with head injuries. Pretty decent head injuries, but still. Alkalosis would be that excessive loss of CO2 in the blood, or hyperventilation. That can come from hypoxia. You can get that from fever if we have severe pain, or if somebody's on a vent and we are not doing our job by venting them properly. So both of these have some things they can change as far as symptoms. You can look over what it would look like if you saw those things. And here is a really, really, really big and possibly intimidating chart on blood gas interpretation. However, it is helpful, and it's something like this that might be easy to print off. Also, I think we skipped. Maybe not, maybe it's the next one. But it is good to look at. Not only does it have whether it's not compensated, partially compensated, or fully compensated, but it also gives you some examples again. So I would urge you to look over this, maybe even print it out and have it in your little packet of whatever you bring to clinical with you, because it would be helpful. So I put these up for you. The cheat sheet on here, I think it's like $6. It's from a cardiac stable program I took for the NICU. And it was the easiest I ever understood blood gases. And you can't put the chart on here, of course, because they have all these copyright things, but I think it's like $6. It's laminated. It is obviously not required. You don't have to buy it, but it is definitely what helped me start to understand ABGs a little bit better. And then I also just put down a extra practice slide on there. If you are like me, you needed a lot when you were learning ABGs. It took me quite a while to figure it out. And like a lot of things, if you don't use it, you kind of end up losing it. So it's good to have something in the back of your head, maybe do these every couple of weeks, just to make sure that you remember it. Otherwise, it's going to be hard to reteach yourself when it comes time to take the NCLEX. On to cellular fluids. Okay. Skipped pages too fast. Sorry, on my notes here. So cellular fluids, intracellular, right, located in the cells. This is review as well. Those are rich in potassium, and this is about 2/3 of your body fluids, typically in adults. And then extracellular fluids, obviously outside. Those are in the vascular area, intravascular. So those are in the blood and lymphatic vessels, as well as in the interstitial area, which is between those cells, right, and outside of the intravascular vessels. So those are the ones that have lots of sodium, and this is about 1/3 of your body fluids. So important for pediatrics, right? Why are infants and children at a greater risk for these fluid volume imbalances, right? Well, newborns have about 75% total of their water, right? The body is water. So they have that highest percentage of body water throughout the lifespan is basically at birth. Those NICU babies are even higher and or worse, right? And newborns have the tiniest little stomachs. We're filling at birth maybe a marble full of what we're able to take in at a time. Hence why they feed every 2 to 2.5 hours. You get a little bigger as infants, and we're going down to 65%. And they still have that high daily fluid requirements, and they don't have a lot of reserve, right? They don't have a lot left in them because their stomachs are still pretty small. And children, we're down to about 50%. Their kidneys are immature. They're unable to either conserve or excrete that effectively, right? They're still kind of trying to figure out what they're doing with themselves. And then the older we get, the better off we are, until we get to be geriatric, right? And then we're kind of back to that same stage of not being able to conserve or excrete effectively. So here is a chart of maintenance fluid requirements, and this is very, very important. And if I were you, I would print this out as well. This is something that will be helpful for you on a pediatric floor. Once, I think I was in peds for about 6 months, I had this memorized. I don't work inpatient anymore, so I have to look at it again myself, but it's definitely something that you need to have to get into clinical with. So this is also based off of a healthy child. This is not based off of a sick kiddo. So this is a maintenance for a healthy child. And this does not include neonates. They typically base their fluid or their requirements off of calories as opposed to the actual fluid itself. So take a peek at this, 0 to 10 kilos. You're going to be giving 100 mils per kilo per day. And what that hourly rate is off to the side. So if you have a provider order maintenance fluids, right, for a kiddo, this is how you're going to figure that out. Sometimes if we're a little extra dehydrated or they want to give them a little bit of extra fluids, possibly before discharge, they're going to order maintenance plus 1/2. Which again is pretty easy if you think about it, but can be intimidating just hearing it. So maintenance plus 1/2 would be whatever you're seeing here, right? Whatever we decide our maintenance level is. Divide that by 2. So let's say our maintenance, this is an easy one, is going to be 10 mils per hour. And we're supposed to give maintenance plus 1/2. So 10 divided by 2 is 5, right? 10 plus 5 is 15. So maintenance and 1/2 would be 15 mils per hour, okay? And I actually have another practice here that we can figure out. So we have a 9-month-old who weighs 8.2 kilos, okay? So we say, well, which formula do we use? Oh, what were we doing off that table? We'll go back real quick, right? So if we're at 8.2, we know we're using the 0 to 10 kilos one, right? So that is 100 mils per kilo per day, okay? So we're gonna do 100 times 8.2, which gives us 820 mils per day. Well, that's not really going to help us. We got to figure out per hour, right? So we take the 820 mils and divide that by 24, and that gives us 34.17, 34.2. Honestly, if you're using an IV, you really don't have to have the 0.2 in there, but let's be specific because maybe this kid's really dehydrated, right? So let's go with 34.2. That's what we would be giving per hour if we had IV fluids on this kiddo. The daily requirement, like we said, that was 820, and maintenance and 1/2 for this kiddo right? We're going to take 34.2 and divide that by 2. You're going to get 17. And 34.2 plus 17 is going to be 51.2. So that would be our maintenance and a half for this kiddo. And if this baby is taking a bottle every 4 hours, how much would we need to feed every 4 hours? I'm going to let you guys figure that one out too. We can talk about that more live, okay? Now, intake and output. Again, this is kind of a review. We do this with grown-ups, we do this with kids, we do this in geriatrics. All ages, we're going to need to be recording their intake and output closely. Make sure I'm on the right slide here, sorry. And an expected amount for infants and children who are less than 60 kilos is going to be 1 to 2 mils per kilo per hour. Children who are bigger, greater than 60 kilos, and you will get big kids in pediatric floor. I had a 17-year-old football player once who was 240 pounds, and it was like, you don't really belong here. You kind of belong in grown-up world, but still considered pediatric, still on the pediatric floor. So we definitely want to make sure we're doing daily weights. Difference in kiddos, of course, is you're going to have far more diapers than you would in grown-up land. We want to make sure that we are scaling out the scale or zeroing out the scale appropriately. So you put that dry diaper on, put it to 0, take it off, and then put your diaper on, and that's how you get what that output is for that kiddo. So funny story, when I was working in pediatrics, my son was about a year and a half, and one night I was very sleepily changing his diaper, and I reached over after I was done to put it on the scale. That didn't exist, of course, because I was at home in his bedroom, but I was in such a habit of weighing diapers and not throwing them away that I ended up trying to weigh my child's diaper in the middle of the night. That's what happens when you're exhausted and have no sleep, right? So here's some practice. So Marcy is 22 kilos and she has voided 620 mils in the last 24 hours. So is this enough for her? Are we happy with her output? So we know she's under 60 kilos, right? She's only 22. So we're okay with 1 to 2 mils, right? 1 to 2 mils. So we have 620, which is what she's done in the last 24 hours, right? We're going to divide that by her weight, which is 22 kilos, and that gives us 28.2. Well, we need to know how much per hour, right? So we got to divide that by 24, which gives us 1.17 mils per hour is what she's put out. So yes, right? That is between 1 and 2. So we feel good about that one. We're happy with it. Alterations in fluid. So we have a fluid volume deficit, right? Which just means we don't have enough fluids, okay? Those are things like dehydration. We're going to get that from a GI bug, vomiting, nausea, diarrhea, unable to keep fluids down, and then a fluid volume excess. This is caused by that water or sodium retention in those vascular and interstitial compartments. Examples of that are congestive heart failure or chronic renal failure. You're going to see less of these kids on the general pediatric floor, but it is still possible. More likely, if we've got a kiddo with known heart disease, a lot of times they go over to the PICU just for better monitoring. And sometimes they go into like a pediatric oncology unit because those are considered clean floors. Whereas if you put a kid with heart disease on a general pediatric floor, there are so many bugs flying around. You don't want that heart kid to get sick. So let's talk a little bit about the fluid volume excess. That can cause those bounding pulses, those neck veins that get a little bit distended, hard to see in little kids, right? Because they're chubby and they have no necks. You can get some of the periorbital edema. You can get an enlarged organs, especially the liver, a little bit of shortness of breath, and definitely those crackles when you're listening. As far as fluid volume excess is concerned, you have to treat whatever that underlying disorder is. You may anticipate an order for some sort of diuretic, some Lasix, things like that. But again, this is not typically what you'd see on a general pediatric floor. A lot of times these kids go to the PICU. So fluid volume deficit, we're going to see this more frequently. So isotonic means that our fluid loss is not going to be balanced by what we're taking in, right? More is going out than we're able to take in. So and this is review too. We should mostly be familiar with this. The loss of water and that sodium is going to be the same. We're not uneven there. So this comes from those GI bugs, the vomiting, the diarrhea, things like that. An isotonic fluid would be just your regular normal saline, 0.9 normal saline or your D5W, okay? That can be given through a regular PIV, no problems with that. Hypotonic Fluid volume deficit is characterized by greater loss of water than sodium. So way more water's going out. We've still got that. And that sodium's not going to. So that serum sodium is low. We get a shift from the extra outside to intracellular, which is going to give you higher level of dehydration in that outside area. This comes from, you're not going to see this in a kid who, you know, just started throwing up yesterday and has been able to keep some fluids down. This is some severe prolonged diarrhea. You may have renal disease, and this is also common in burn patients, which I don't think we cover in pediatrics. I think you cover that later on. So a hypotonic solution example would be your half normal saline. Hypertonic would be that fluid loss that it has more loss of water than soda, which I think I have a typo in there, which I will fix. So your serum sodium is high, right? You've got more sodium out floating around. So the onset of your symptoms usually are delayed because you have those compensatory shifts again. This comes from things like diabetes insipidus, and a hypertonic fluid would be like D10W. You're not giving that in a general pediatric floor. This kiddo is going to the PICU. This is not something you want to be trying to deal with while you have a higher patient load. So on to our exemplar. I'm sure you guys have heard that word 6 million times. We are looking at dehydration specifically. So we go back to that history and assessment, right? Who is most at risk for this? So we've already talked about this a little bit, but this is going to be the infants and small children, right? They have smaller stomachs, and you can't convince them that they need to drink more because it's going to actually make them feel better, right? Anybody ever have tried that conversation with a 2-year-old? Does not work. So again, you want to ask parents, guardians, whoever's there, that old carts and news questions, because that's going to help us figure out how dehydrated they are. How long this has been going on, and maybe everybody else in the household's been sick too, and they already know what it is. Again, that's a big help. So check out our overall appearance and behavior, right? Are we crying? Are we awake? Are we laughing? Are we giggling? Are we sleepy? Physical assessment. This is, again, all things that you guys should be doing. Vitals, height and weight, and especially when you're looking at dehydration, you're going to pay attention to the mouth. Is it dry? Is it cracked? Do we have tears? Do we not have tears? Just because we have tears does not mean we're not still dehydrated. That's kind of a later sign. That's a, uh-oh, we've missed something kind of sign. So as far as diagnostics go, I think we've got that on the next one. We don't have it on the next page. I swear I have it on here somewhere. Yes, I do. I have it later. Sorry. Causes of dehydration. Emma says, of course, we know vomiting, diarrhea. As far as diarrhea goes, there is the rotavirus, which when I first started out in pediatrics was a big deal. You could walk down the hallway and you knew somebody had rota in the hospital. You could smell it from that patient room. Like that whole hallway stank like rota. Thankfully, they have come up with a vaccine for this. So babies get it as a liquid oral vaccine. They get child checks, and it basically has gotten rid of the problem of rota, which causes severe dehydration in kiddos. C. diff, this is why our history is so important. We know C. diff can come after we've had antibiotics, right? Maybe this kid just had an ear infection and was on Augmentin for that. So it's important to ask those questions. Less common, of course, would be something like parasites. We'd be getting hepatitis, things like that. But again, something to think about. Dehydration causes could also be failure to thrive. I had a parent come in one time with a 2-month-old little boy who was definitely dehydrated, and she didn't realize that she needed to be increasing the amount of formula that he was getting, and her concentrations were off on what she was doing for formula. So he ended up being severely underweight and dehydrated because of that. Economic issues are also something to think about when it comes to formula specifically, right? We always want to make sure that we are mixing the formula to the directions on the bottle, mostly because it can mess up the electrolytes on that. But sometimes, we're going to end up with dehydration because, they aren't able to buy Pedialyte and the kid's not keeping anything down, things like that. So here's some better diagnostics there for the fluid and electrolytes. So kind of like before, right, we can run a CMP or a BMP. It's going to give us our electrolytes, our CO2, which is really a big thing that we look at in pediatrics as far as dehydration goes, right? If our CO2 is down, we know this kid needs some fluids. Your BUN, your creatinine, your glucose, all things that you look at normally, right? You can get just a BMP in kiddos, but if they're coming in and it's their initial diagnostic there, usually the provider is going to want more information. If you have to poke a kid already to get labs out of them, the best you can do, or the nicest thing you can do, is only poke them one time, especially if they're already dehydrated, because it's not going to be an easy poke. So get what you can the first time. CBC we've talked about. UA, that spec gravity is normally 1.002 to 1.030. And you know, the higher that spec gravity, the more that kiddo is going to be dehydrated. So as far as ABG goes, we'll talk about that more here in just a bit. They are not routinely done by any means. An ABG is not typical on a kid coming in unless we are severely dehydrated and the kid's going straight to the PICU, came in by ambulance, something along those lines. So as far as categorizing dehydration, this is not something that you necessarily have to do officially, but it's really helpful as far as what to be anticipating from the provider, things like that. So you're looking at their thirst or their skin turgor, what their pulse rate is, their respiratory rate, and this shows kind of what would be mild, moderate, or severe. The percent of body weight loss is important, and we'll get a little bit more of that here in a few minutes. But definitely look over this. Again, this might be a helpful thing for you to print out and bring with clinical. I know at least I had one of those fancy clipboards that had you could open it up and stick all the papers inside that you needed for review. I don't know if anybody still carries those, but that did help me a lot when I was doing clinicals. So calculating the weight loss percentage. So something that I'm sure that everybody could do here without me talking you through it, but I'm going to do it quickly anyways. You just take that previous weight, subtract it from the current weight, and that gives you your weight loss. You take that weight loss number and divide it by that previous or initial weight, and you get a number, right? But we know that's going to be a 0.0 something. So you multiply it by 100 to get the percentage lost. So I have an example for you. Harper is a 7-year-old female who got admitted for vomiting and diarrhea. And the provider is trying to decide if they want to start some IV fluids or just try to do some oral rehydration. Mom happened to weigh her yesterday morning. She was at 23.5 kilos, and this morning her weight is 22.7. So we're going to take that 23.5 minus 22.7, right, which is this current one, and we get 0.8. So 0.8 divided by yesterday morning's weight, 23.5, gives us 0.034. We're going to multiply that by 100, and we're going to get 3.4%. So that's how much she's got on her weight loss percentage in the last basically 24 hours is 3.4%. So let's go back to our chart here. And so based on this chart, where does she lie? When we're not assessing her now, so you can't look at any of that stuff, but just based on that percentage, she's still at mild. So that's good. We're not super concerned yet. A nursing diagnosis as far as dehydration goes, things we're looking at would be a fluid volume deficit. That is your number one thing you should be thinking of for a nursing diagnosis. Other things to think about would be that risk for electrolyte imbalances, risk of ineffective tissue perfusion related to that blood flow, activity intolerance, right? We're not going to be able to do a lot of things. We're going to be tired. We're going to be cranky. We're going to be a little bit weaker. And then risk for impaired skin integrity due to that poor perfusion. So, excuse me, make sure, especially in infants, we're moving, we're rolling, we're doing things like that. So as far as interventions go for oral, first would be oral rehydration, right? We don't want to stick an IV in a kid if we don't have to. You can use oral rehydration along with IV fluids as well. So a way to help with that would be ondansetron, which reminds me of a reindeer from Santa. I mean, can't you just hear it? Like Donner, Blitzen, ondansetron, makes me laugh every time. I did include in the reading for this week an article on pediatric rehydration and the ER that is very helpful, and it talks about the role of ondansetron in helping to rehydrate. So take a look at that. It's a pretty easy to read article, and it has some good information in it. So as far as the oral rehydration choices, if we are a breastfed baby, that breast milk is going to be the thing it's most used to. It's going to be more likely to drink that way. Formula, Pedialyte, and then low or sugar-free popsicles are all good choices. We don't want them hopped up on sugar as they're eating popsicle after popsicle if we can help it. We definitely don't want a lot of cow's milk or sugary drinks if we're having nausea, vomiting, diarrhea. Apple juice can actually worsen diarrhea, so that's something to think of. Now, if it's the only thing that this 2 or 3-year-old is going to drink, cut it with some water. Make it a 50% apple juice, 50% water, 20% apple juice, add some Pedialyte into it. That's helpful. Another thing that you may see on a pediatric floor would be the provider putting in orders for half-strength formula or quarter strength, meaning that their stomach is not tolerating their formula right now. They're unable to keep it down. But if we do half of that regular mixture and then half of Pedialyte mixed in, they may be more likely to keep it down. It's not as hard on their stomach, and we're keeping them rehydrated orally without having to do all of the IV fluids. So I think that's it for the recorded lecture. We are going to go over this all again on the 16th, and I will go through things maybe a little bit more in depth. Some things we'll just touch on because at this point you should have had some time to practice, do some research, do some reading, figure it out. I do have some more practice we'll do, as well as a big case study and a few other interactive things. So I don't have an official school email yet, but you can send anything on to Rebecca and she can forward it to me at this point. If you have any questions, you're more than welcome to contact me, let me know. And I think that's all I've got for now. So I will see you guys next week. I hope you're having a good week, enjoying this weather because it's phenomenal. And I look forward to seeing you next week. Thank you.